Hello and welcome to our webinar on Inside Out Mental Health and Pediatric Long COVID. My name is Megan Carmelani, and I'm speaking to you today as both as someone who has lived with infection-associated conditions since childhood and as a leader of a nonprofit that supports children with long COVID and their families every day. Let's begin by affirming what we already know. Long COVID is real and it is biological. Thousands of studies now document immune dysfunction, nervous system disruption, organ damage, and cognitive challenges after a COVID-19 infection, and much more. These are measurable physical impacts, not speculation or misunderstanding. Researchers have also characterized what long COVID looks like in children across age ranges, using comparison groups to identify clear patterns of symptoms that can significantly disrupt children's lives. At the same time, many in our community know what it feels like when mental health is misused to explain away physical illness. Families often fear that if they say their child's struggling emotionally, they may not be taken seriously. That fear is real and justified. But we cannot let that fear prevent us from addressing everything children. Mental health symptoms can be part of long COVID itself, reflecting how the virus affects the nervous system, immune system, and drives inflammation. And living with long COVID can also take a profound toll. The isolation, loss of normal life, and ongoing uncertainty affect children and their families deeply. This webinar is about creating space for both of those truths. We're here to talk about the mental health, not to minimize this illness, but because long COVID affects the whole person, body and mind, and because no one should feel isolated or afraid to ask for help, especially not children. We hope today's conversation helps reduce stigma and fear and opens the door to better support, healing, and connection. We are fortunate to be joined today by three outstanding speakers: Dr. Richard Gallagher from NYU Langone, who leads mental health research for Recover, a national research initiative studying long COVID in the United States; Dr. Megan Fitzgerald, a researcher with the Brain Inflammation Collaborative, as well as the Patient-Led Research Collaborative; and Dr. Alexandra Yonts, pediatric infectious disease specialist and director at the post-COVID program at Children's National Hospital. Thank you all for being here. Now, please submit your questions in the Q&A forum at any time during the webinar. And before we turn to our speakers, I would like to start with a quick poll. You'll find a link to the poll in the chat. Please take a moment to click that link and respond. So we'll just give it a moment. There it is, it's in the chat now. So the first question we'd be interested to hear from you on: do you feel that mental health is adequately addressed in pediatric long COVID care? Oh, 3 so far, no. 1 is not sure. We'll give it a few more. It looks like the overwhelming majority say no. That makes sense. We'll go over some really good information that hopefully will help. So now I'm honored. Let's move on. Now I'm honored to introduce our first speaker, Dr. Richard Gallagher, a researcher at NYU Langone and the mental health lead for the Recover Clinical Science Core. Dr. Gallagher brings valuable expertise on advancing research to understand the neurocognitive and mental health challenges children and adolescents face due to long COVID. I'll hand it over to you.
Thank you. And I appreciate being here and being asked to join in. I will be going over information that is about population health and group information. I am a clinician, but I'm not a clinician for long COVID cases. And so I will be going over information that's been gathered in research over time. I do have just a disclosure that I am being supported by the Recover Initiative, and that's on the first slide. But otherwise, I do not have any other conflicts of interest. I'm going to talk about both neurocognitive functioning and well-being in pediatric cases in terms of what we know and understand. So we can go to the first slide and then kind of move on quickly to the one right after that. So here's information that is coming from the main pediatric cohort study design in the Recover project. It is gathering information and has gathered information on a large number of persons between the ages of 0 to 25 years. So it does include young adults as well as kids. And there's tiers that have been conducted. In tier 1, there's a number of different broad scale surveys that have been conducted that have been reviewed in the very beginning and gathering information on persons' exposure to COVID. And those persons are continued to be followed. The research is gathering information on persons that have been exposed to long COVID and some persons that have been clearly indication as not having an infection. At 6 months, 12 months, 24 months, 36 months, and 48 months, there's another set of studies that are being conducted of the physical, mental, and neurocognitive functioning that are being gathered with in-person interviews and some also some surveys. And then for a smaller number of persons, which is tier 3, there's a review of persons for about 600 members of the population that's originally sampled, and it's being looked at very carefully. So that's the kind of broad design from which we're getting information from Recover. So next slide, please. Because what we want to understand is that there have been understanding of viruses and post-viral syndromes for a while. And we'll go to the next slide with regard to some of the historical information about that. These are ones that have been studied over time. And the 1980 Spanish flu was a worldwide pandemic that lasted for 5 years with several waves. And it did also overlap with a pandemic of encephalitis lethargia, which started in 1917. The human immunovirus has been studied extensively. And some other COVID viruses, the SARS virus and the MERS virus, they are a shared respiratory infection. And the SARS situation was from 2002 to 2003, and MERS was in 2012. And those affected certain areas of the world. And the H1N1 is another virus that was around and prominent, started in 2009. And these are all ones that have been studied extensively. We'll go to the next slide to talk about what we know about this information. More study is needed, but basically, in terms of understanding things from the understanding the impact that coronavirus may have had, the 1918 pandemic and the encephalitis lethargia have had limited utility. Although it is known they are a different kind of virus, but at the same time, it is known that both of those did result in changes in mental functioning. And starting with some neurological changes that may have had an impact on behavior. It's interesting that HIV has not been a particularly good model. It's a very different kind of physical characteristics. And SARS, MERS, and H1N1 have greater utility. And so far, what we know about COVID so far is that there are neurological issues that are present in a sizable number of hospitalized patients. That's been documented of people that have had really severe infections. And interestingly, what's also known is that relative to the population of infected persons at large, between 0.5 and 6% of people have had neurological complications, and those are pretty significant ones. They've included encephalitis, they've included seizures, altered mental state, some dementia, different forms of psychiatric conditions that emerge after including psychosis, and some cerebrovascular events in the acute phase of the disorder. General recovery has occurred from other aspects of the disease, but a fair number of reports of lasting impact in the form of brain fog, general fatigue, headaches, and dizziness have also been documented. And we'll talk about some more details about that with the next slide. The So far, what's been found is that similar to SARS and MERS, the spike proteins in the COVID virus bind to enzyme in the lungs, as well as enzymes in the gastrointestinal system, kidneys, and the heart. And interestingly, COVID-19 has been shown to have 10 to 20 times the affinity for these enzyme receptors. Now, there's many different ways that the central nervous system can be affected by the virus. It can get into the circulation, and it may result in circulation in the central nervous system, possibly causing the virus to bind with nervous system enzyme receptors. And this nervous tissue does have these enzyme receptors as well. It's been found that the coronavirus has been found in the cerebral spinal fluid of patients. So it is known that it does get into the central nervous system. And there's been a proposed number of certain neuropsychological concerns, and a broad range of concerns have been proposed without the exact mechanisms being clearly understood yet. Data is being collected for pediatric samples, and we don't have a large proportion of pediatric samples with severe disease in the early acute phases, and it's small relative to adults. And there's been issues with regard to determining who has been exposed and the nature of the exposed, and also the illness course to be collected, so that there's many factors being reviewed. We will take the next slide, please. And there have been a myriad of psychiatric concerns that have been present with regard to things since the pandemic occurred. There is definitely potential direct CNS impact of the virus in the brain. So the brain is impacted, and there's lots of evidence that has happened for a number of people. We do also need to take into account, in terms of psychiatric concerns, that COVID exposure can result in illnesses that result in some post-traumatic stress disorder for persons that have very serious complications when they first have the acute phase. And there's also can be, as Megan was highlighting, psychiatric reactions to changes in functioning, which are real reactions. When you can't do things, you are prone to being able to have a couple of different reactions to that. There's also the consequences of illnesses that have affected others. Kids can be affected by grief reactions. They may have lost important persons in their lives. And there may be also increased stress in caring for others. With regard to the public health responses to the outbreak in both COVID exposed as well as controls, there is a response to increased isolation that may have a long-term effect. There's an increase in social anxiety that was present, and societal anxiety about the nature of things. And there has been a response to changed economic status. So again, many people did lose their positions or were not able to continue to function in their positions. So the adults around children who were affected by COVID or indirectly affected may be occurring as well. So we go to the next slide, please. And here are some of the different myriad of psychiatric concerns that might be present. And there's a lot of different factors that have to be considered. There is first the COVID exposure. There's also the treatment experience when a person has had COVID and what occurred at that time. There can be changes in functioning and the quality of life as a result of that. There can be an experience of significant others, including loss, so that other people around the kids could have been affected. And then there's the change in the general environment in response to the the public health issues, and all that can result in contributions to psychiatric outcomes and mental health outcomes. Next slide, please. And again, based upon prior research, here's a summary of that work that's been looked at in terms of understanding things with COVID. And let's go ahead and anxiety is likely to be prevalent. It can be present only in the first months, but it can persist. Depression is likely to be prevalent with indications of, again, also persistence. And I do want to be able to make sure and be clear about this, that this can result with an impact on the central nervous system, nervous tissue, not necessarily because persons are developing these things without having their nervous system directly impacted. PTSD symptoms can be present, including anxiety and depression, and it's likely to be present in those that were hospitalized, and especially those required ICU treatment. Psychosis has been reported at a higher rate than under typical circumstances, and this has been documented with adults. And the mechanisms for change are not well understood, but there's more understanding. And its candidates include increased inflammation of central nervous system tissue that can result in the central nervous system not functioning as well and not responding as well to anxiety situations and situations where mood can be affected. And it's not clear completely if COVID-19 is neurotoxic, but it is believed that it is very likely to be so. We'll go to our next slide. Oh, I'm sorry. Comparing to the control groups, limited COVID exposure is critical, and so that's what some of the work is being done in a number of different studies. And we can go on to that next slide for that. And we want to be able to remember about the pandemic environment and how it's affected everybody. There's been a loss of functioning. People with long COVID are having more tiredness. We'll talk about some of those details. There's reduced energy, and there has been a loss of loved ones and close friends. Over 1 million people in the U.S. Died, and 500,000 of those people were below the age of 75. And in terms of the likely prevalence of prolonged grief, general studies find that 1% of persons who have had a loss suffer from prolonged grief disorder. And following the death of a loved one through COVID-19, there's a small number of studies. Some found no difference from the rate of other natural causes, but one study found that a rate was higher than at least 2 times the rate of other sources of death. And basically, there's been about 13,700 adults that are likely to suffer from prolonged grief. And in terms of the number of kids, it's also likely to be a high number of kids that might be suffering from prolonged grief because of the loss of a loved one. Next slide. And the number of children who lost a parent or parents, it's estimated that about 200,000 kids lost a parent or in-home care caregiver. And that's likely to be about 40,000 current or future cases of kids that may have a risk for depression and suicidal variations because of this early loss in life. Thank you. Next slide. We can now also say that there's been an impact of economic loss for the family. There's underemployment and unemployment, and those are associated with more psychiatric illness subsequent to the employment change. And again, this is not because of people having, just elevated psychiatric issues themselves. It really is a reaction and response to what has happened because of this situation. There's a reduced social and school context during the economic response. And so there's isolation, there's issues with work experience, and there's a deterioration in education. And there's a significant change in youth disorder rates. Next slide. And here's what we talk about in terms of the pathways to the CNS impact. It may be that the blood-brain barrier was crossed through this binding to an enzyme. There is an indication that the cribriform plate, which is just above the mouth and just below the olfactory bulbs, may be things where it has passed through, and this may be reflected in the loss of sense of taste and smell. And in addition, the virus itself can trigger a disease process that causes systematic inflammation that has been found in the central nervous system. Next slide. And in terms of also, not in addition to the psychiatric concerns, there's also a number of neuropsychological concerns. And this is the areas that help us with our thinking and help us, again, especially kids, learn and function effectively. And there's a change because of COVID. There's an exposure to these issues. And then there's the treatment experience as well that can have an effect. All these different factors can result in some changes in people's neuropsychological functioning. And here's some information about the nature of neuropsychological functioning in the next slide. There's been changes in school delivery that's affected everything. There's an indication that 25% of instructional time was lost. And for elementary school children, that has resulted in reduced verbal input, time to learn to read, spell, and understand early math. And there's the overall estimates of loss of 5 months in math achievement and 4 months in reading achievement because of things. We'll go on to the next slide, please. And there's been these different sources of information about what has happened. There's been medical records review for patient symptoms and complaints, and also clinical exams. There's been questionnaires completed by caregivers and youth. And then there's been assessments with varied neuropsychological tests. We'll go on. And there have been indications of developmental risks for neonates and infants, for persons exposed to COVID during pregnancy. It's resulted in an increased rate of preterm birth. There's been an increased rate of neonatal intensive care unit referrals. And if this was true, especially for mothers who had a moderate to severe illness, there was a 13-to-1 ratio of the kids going to the neonatal intensive care use. And a large-scale study did find that there was pregnancy complications, more preterm birth, low birth weight, and all more significant, especially if pregnant were symptomatic. So kids have been affected indirectly because of what's happened during the time when their mothers were pregnant. Next slide. We also find some information about children and teens. From medical records, concentration has been listed in 8 of 9 different large-scale studies that there's been problems with concentration. The range is broad. Most indicate that it's happened in 3 to 10% of kids with long COVID, but some as high as 61%, and memory problems were also reported. And with regard to objective testing, it's found that estimated that 10% of youth have long COVID, and that there needs to be an alert understanding for executive function problems, memory problems, attention problems, and verbal fluency problems. Next slide. And the patterns in terms of post-viral disturbances, the estimate prevalence, varied results from systematic reviews indicate that 30% in moderate to severe case and 29% in moderate alone. So again, these issues with regard to post-viral disturbances are not rare. In terms of the behaviors, that takes the form of brain fog, problems with memory, attention, and fatigue. And in long COVID, there's been a number of different studies with 50% in one study reported to have problems with attention confirmed, which was confirmed by testing. And compared to the standards on attention and memory testing, kids with prior infections, 52% and 40%, 42% had below average score. So again, we're getting lots of documentation that these issues are definitely present. Next slide. We'll continue with some of this information. There's been also structural and functional brain imaging studies that are finding that in both long and acute COVID, there's changes in the gray matter volume in the limbic system and the hippocampus in adults. If this is being investigated in kids, the limbic system has a lot to do with emotional processing, and the hippocampus has a lot to do with the management of memory. Again, there's a number of different things that indicate that there's these structural and functional changes, and we'll go to the next slide. And in terms of the population health summary, and again, this is groups of people, there's an increase in psychiatric complications due to reduced or loss of functioning. There's an increase in prolonged grief disorder that can there's an increase in child, adolescent, and eventually adult risk for depression and suicidal behaviors following caregiver loss. There's an increase in psychiatric complications due to changes in employment and financial status. And there is an increase in varied youth psychiatric conditions, which importantly are the precursors to adult disorders. And we'll go on to the next slide. And conclusions from the Recover Tier 1 assessment. This is looking at a large sample of people filling out reports by caregivers on their kids. COVID-19 exposure has contributed to neurocognitive and mental health concerns in children and teens. They've been found to be persistent in kids that are with long COVID in this study. Of the full sample of people studied and recovered, 3% of school-age kids and 2% of adolescents are rated with fair to poor health. But for those at high levels of empirically derived problems, indicating that they have a number of different symptoms connected with long COVID, 18 to 20% of school-age children and adolescents have a fair to poor parental ratings of health. 5 to 14% of infants and preschoolers have fair to poor parental ratings of health, and 6 to 13% have poor to parental ratings in reacting developmental milestones. And the issues that are present are tiredness and pain symptoms are reported, but however, 35 to 47% of school-age kids and adolescents report anxiety and depression, and also very high levels of memory concerns. And we find I have one final slide to kind of go over and just talk about. In terms of clinical case studies, we also have information indicating that of these different recent clinical case studies, and this is not comprehensive, this is not exhaustive. But again, in looking at kids, there's increased rates of depression and anxiety, and also increased rates of concentration problems, and those are some of the different major factors that are present here. So again, more indications can come from studies of long COVID that I think we're going to have from people that are also on this panel. But again, the population health studies certainly document that many kids with long COVID are demonstrating concentration concerns, anxiety concerns, and depression concerns that were not present before they were exposed to COVID, and were not present only because they had an acute case of COVID, but it's been documented in those kids who are showing long COVID patterns. Thank you.
Wow. Thank you, Dr. Gallagher. I'm a former teacher as a reading specialist. So as you're talking about the impacts on children, and that's going to show up in the classroom. We often get questions from teachers about long COVID. But thank you for that. It's really important to share.
Sure.
Next, I'm pleased to welcome Dr. Megan Fitzgerald, a researcher with the Brain Inflammation Collaborative, as well as Patient-Led Research Collaborative. Dr. Fitzgerald will share insights from the research and discuss how inflammation affects mental health. Thank you. Hi, Megan.
Hello. Let me just share these slides. All right, here we go. Thank you so much, Megan, and thanks for hosting this incredibly important and timely webinar on mental health concerns in long COVID. My name is Megan Fitzgerald. The title of my talk today is Hidden Wounds, Neuroinflammation, and Mental Health in Long COVID. Neurological symptoms are common in children with long COVID. And just to review the definition of long COVID is defined as symptoms that last for over 3 months post-infection. The initial COVID infection is typically not severe in people with long COVID, but it can be severe. Symptoms of long COVID can range from relatively mild, like persistent headaches, to truly debilitating symptoms that interfere with daily function and life. There's a multitude of long COVID symptoms. Patient surveys have reported over 100 different symptoms, and these symptoms can range from ones that affect organ groups like the heart, the lungs, the kidneys, to symptoms like rashes, persistent cough, or sore throat, to long-term sensory disorders like loss of smell and taste. However, many of the long COVID symptoms that are typically rated to be the most disabling are related to neurological, neurocognitive symptoms, or mood symptoms. And unfortunately, these symptoms are often also the most difficult to find treatment for. And these symptoms might be related to neuroinflammation or an immune response in the brain and spinal cord. There's growing evidence, as Dr. Gallagher was speaking about, of the mental health impact of long COVID. And there is, of course, as he alluded to, a natural response of sadness, anxiety, and other emotions when you're living with a chronic illness. But there also might be something more, the same inflammation, the same damage or immune response that underlies the physical manifestations of long COVID might also be causing problems with thinking, sleep, mood, and behavior. And that's what I'm going to be discussing for the rest of the talk. In the next 2 slides, I'm going to speak about how the brain interacts with the immune system. And this is important to understand because a lot of the neurological and neurocognitive symptoms of long COVID might be arising from neuroinflammation that could be being driven by dysfunctions of the immune system in long COVID. So you might have heard about the blood-brain barrier before. And this is an illustration of the blood-brain barrier here. In the blue panel here. The blood-brain barrier, it's not like some people might picture it as a sort of gatekeeping apparatus at the level of the neck. I think that's actually how it was first explained to me in like 5th grade. But it's actually formed by these very specialized cells that surround the blood vessels that go throughout the brain. These cells include endothelial cells, astrocytes, and pericytes. The endothelial cells are the lining of the blood vessel. The astrocytes you can see here in the medium blue color And they form kind of a barrier around the blood vessels in the brain, and the pericytes can control the dilation and constriction of these blood vessels in the brain. The purpose of the blood-brain barrier is to protect our very precious neurons from toxins and pathogens. And pathogens might include viruses and bacteria, while at the same time allowing for the nutrients that the brain needs to pass through. And this is done by these tight junctions shown here in this inset diagram. These tight junctions are gatekeepers to the brain, but they're also sensitive to chemicals that are released by immune cells like cytokines. And these chemicals can make them more permeable, and then they can increase neuroinflammation. Now, under most circumstances, the immune cells that circulate in the blood, like white blood cells, are kept out of the brain by the blood-brain barrier. So the brain has its own immune cells. These include astrocytes and microglia. Astrocytes can respond to injury and disease, and if you recall from the previous slide, they also form kind of the barrier around the blood vessels and are integral to the formation of the blood-brain barrier. They can also communicate with immune cells, and they can release their own chemokines and cytokines. They can block off sites of injury or inflammation by kind of walling off that area of the brain to protect the healthy part of the brain. And I wanted to show some actual micrographs or pictures taken with a microscope of these amazing cells because they're truly beautiful. These astrocytes are shown here. In the upper panel, the astrocytes are shown in red, the neurons are in blue, and you can see how intricately they are intertwined together. In the bottom panel, you can see it gives you a slightly better idea of the scale and the size of how big this neuron is. The neuron is in green in the bottom panel, and the astrocytes are surrounding it in red. Now, there's another important glial cell type. It's an important player in the brain's immune system. This is called the microglia. Microglia can become activated in disease states, and they can also release inflammatory factors. They can engulf pathogens and cellular debris, and what I mean here by cellular debris is fragments of cells that might be injured or hurt or even dead and dying cells to prevent inflammation cascades and to prevent damage from those cells to other cells that are in the area. But overactivation of microglia can interfere with their normal function. And I'll just explain in this panel here, this top microglia under the microglia heading here, this is a healthy, happy microglial cell. You can see its cell body in the middle, and then it's sending little processes out into the brain environment, the brain tissue environment around it. It's sensing, what the brain needs. It's sensing the different nutrient factors and what's happening. Now, if you go to the bottom panel, panel C here, this is an activated microglia. This is called actually an amoeboid microglia. And this one might be involved in engulfing something that's toxic in the environment and digesting it. And in the middle here, this panel B, this is what is known as a hypertrophy or an activated state. So this is somewhere between these two states. And that microglia in the middle, it's not in the process of engulfing anything, but it is in the process of just being too activated to fill its normal role that it would fulfill as a healthy microglia, where it might be helping the neurons at synapses and helping the brain with learning and memory. And this can indicate, some sort of immune dysfunction where these microglia remain in this activated state instead of in this healthy, resting ramified state. There are other immune cells in the brain as well, like mast cells and perivascular macrophages. So if you recall from the previous slide, activated microglia are a response to stress. For example, signals from the immune system or from pathogens like a virus, but they can also be in response to elevated emotional stress. In conditions like depression, There are increased activated microglia in the brains of depressed people who died by suicide. And in patients with depressive episodes, the astrocytes were also activated. They had longer, more intricate projections, which can suggest increased reactivity. There were also fewer astrocytes in brain regions that were associated with mood in depressed subjects. And this can lead to a weakened blood-brain barrier that has been seen in a number of studies on depression. In bipolar disorder, there's evidence of altered astrocytes as well, and increased microglia activation in people who have bipolar disorder. So this state of neuroinflammation is also associated with mood and behavioral disorders. And it's also seen in long COVID. And this really dramatic image here, this is a study, a very small study that looked at a radioligand. So this was a PET study, and a radioligand that can bind to activated microglia in the brain. So you can see these top two images here are from two patients with fairly severe long COVID. Their symptoms included severe fatigue, neurocognitive problems, and they were too disabled to work. On the bottom here are three healthy controls. And this heat map scale shows red is a high level of binding. This purple, blue, and black colors are low binding. And you can see the really clear differences in microglial activation in this small study in terms of the binding affinity for the microglial cells that are activated in the people with long COVID. So what may be causing neuroinflammation in long COVID? I'll revisit the mast cell. If you recall, these are immune cells that are in the brain as well as in the rest of the body. These cells can become activated in long COVID, and mast cell activation is when mast cells release components like histamine, proteases. Proteases can degrade proteins in the body as well as cytokines. Histamine and cytokine production from mast cells can then trigger microglia activation as well as microglia proliferation. And histamine and mast cell activation can create a vicious feedback cycle when the astrocytes are damaged, because mast cells release histamines and other factors. This can activate astrocytes, which release more inflammatory factors. This then activates the mast cells in the brain, and you start back at the beginning with the histamine release. And this vicious feedback cycle is implicated in other neuroinflammatory diseases like multiple sclerosis. And this mast cell activation can then lead to degradation of tight junction proteins. And if you recall, these are the really important proteins in the blood-brain barrier that can protect the brain from things in the periphery and the rest of the blood and body. And this dysfunction of the blood-brain barrier, there's a lot of evidence of neurovascular damage and scarring in acute COVID-19, as well as evidence of blood-brain barrier disruption in long COVID patients with brain fog. Persistent immune activation may also contribute to neuroinflammation in long COVID. Lingering virus or viral fragments even might be triggering a long-term immune response in people with long COVID. And autoimmunity may also be another problem with immune activation in long COVID. New onset autoantibodies were found in 55% of unvaccinated infected patients in the study that was published in 2024, and they were associated with neuropsychiatric symptoms. I will say a number of the patients in this actually had a severe acute initial COVID infection. Now, there are also post-COVID brain changes in children, but pediatric research is lagging behind that in adults, despite the fact that pediatric and developing brains are uniquely vulnerable. Kids are rapidly growing, learning, and changing, and we don't know yet what the long-term effects of a COVID infection or long COVID during key developmental stages of childhood or the teenage years are going to be. So it's incredibly important to study and to better understand this. And as Dr. Gallagher was speaking about there, it's what the Recover Initiative is aiming to do. So I'm showing here a study that showed brain differences in very young children. And this is one of the few that was looking at mild acute COVID infection. There are a number of studies that showed changes to children's brains post-COVID-19 in hospitalized children. But in this study, this was with a mild acute COVID infection, and the average age of these children was very young. The average age was under 4 years old. There were about 20 children per group. It's one of the few studies that examined children's brains after a mild COVID-19 infections and was published. And they did find different patterns in the thinking, the regions of brain activation during certain tasks. So I just want to use this also as an opportunity to plug for more funding for long COVID studies in children and teenagers, because we really need this in order to understand long-term neurodevelopmental outcomes. So I want to go back to this word cloud that was showed on one of my initial slides about the symptoms of neuroinflammation in children with long COVID. These include fatigue, brain fog, depression and anxiety, irritability, vertigo, migraines, tinnitus, dizziness, sleep disorders, tremor, and headaches. And some of these changes in mood and behavior might be among the first symptoms that are noticed by caregivers. The physical symptoms, like POTS, for example, which many people with long COVID have, might mistakenly be attributed to psychiatric causes when inflammation is actually the driver of both psychological and physical symptoms. And there's no single diagnostic test for neuroinflammation, unfortunately. All this data that I'm showing is from laboratory studies. You can't, at this point, go to a clinical office and ask for a test for neuroinflammation. And in this way, long COVID has commonalities with other post-infectious disorders like PANS and PANDAS and ME/CFS. So why does it matter if symptoms are from neuroinflammation? This has clinical implications because patient care needs to be integrated. The physical and mental health symptoms are probably just different sides of the same coin, and children with long COVID might not respond well to traditional psychiatric therapies for mood and behavior disorders. You can see here a diagram from a study on long COVID in children where neuropsychiatric symptoms are among the most common that are experienced, but are often found in the context of these other physical symptoms. I also want to say that the brain can heal with appropriate treatments and time and support. And there is hope for better treatments that address the root cause of mental health symptoms in long COVID. This is a very incomplete list of therapies that are in trial and therapies that need to be trialed further. These include antihistamines that can block mast selectivity and reduce histamine effects on the brain cells like astrocytes. Low-dose naltrexone, or otherwise known as LDN, which can shift microglia from activated to resting states and promote neural repair and protection. IVIG, or subcutaneous immunoglobulin, that's SCIG, and other immunomodulators may suppress the inflammatory response, including by decreasing cytokines. Probiotics can even help. The health of the microbiome influences the gut and brain axis, and this can also decrease the activation of microglia. Antivirals could be used to treat any pockets of lingering virus or viral fragments that could be triggering a long-term immune response. And of course, these can be given in conjunction with supportive care, like rest, pacing, physical, occupational, or cognitive therapies, and school and work accommodations, which are necessary to help people heal from long COVID. So in terms of the key take-home points here, neuroinflammation is a biological reality that may underlie many long COVID symptoms in children. Children are not making it up. There are real brain-based and immunological changes in long COVID. And early recognition, validation, support, and appropriate treatment can make a big difference. And this is why it's important to understand the effect of neuroinflammation in long COVID. I am happy to take any questions in the Q&A, and I will do my best to respond to them. I'll hand it back to Megan C.
Hey, Well, thank you very much, Dr. Fitzgerald. That was really helpful. Excuse me. And I please encourage you guys to put any questions you have in the Q&A. Take your time to do that. And finally, now we have, and I'm very happy to introduce Dr. Alexandra Yonts, the Pediatric Infectious Disease Specialist and Director of the Post-COVID Program at Children's National Hospital. Dr. Yonts will speak about what she's seen in clinical practice and what families and providers need to know about caring for children with long COVID. I'll hand it over to you.
Thanks, Megan, and thank you to the other presenters for setting a good base about what I'm going to discuss here. Hopefully, yeah, you can see my slides. So this is the psychological impact and interventions for long COVID in children and adolescents. I really am going to focus just on the mental health aspect, which is related to, but a subset of the overall, interventions and treatments that our children and the children with suffering long COVID need. So I don't want to make it appear that what I'm talking about is the be all end all of treatments. Far from it, but it is complementary to any medical treatments that we also do for these patients. Okay. So just a few disclosures. I am a principal investigator on a few vaccine clinical trials that are conducted by Pfizer, and my institution received funding for that. And then I really want to give a shout out to Dr. Linda Herbert. So she's the psychologist in our post-COVID program clinic, and she made these slides. She was hopefully going to be with us today, but unfortunately had to attend the funeral of a family member. So she graciously let me borrow her slides, and I'm sure she's happy to answer any other questions as the expert at a later date. So objectives for this talk, really very briefly identify the primary symptom presentation, since that's been gone over by both of the prior speakers at length, and then describe some of the common treatment approaches that we use in our clinic, and sort of the thoughts behind that use. So briefly reviewing, as Dr. Gallagher and Dr. Fitzgerald really hit on, but there, some more recent research has really noted that kids with long COVID suffer from cognitive issues like memory and concentration defects, anxiety, and stress, and that also causes a fair amount of distress in and of itself, having those symptoms. And multiple other studies have shown that, early on, there was lots of questions about how much of this symptomatology, especially the anxiety, could be related to external factors, so the COVID pandemic and sequelae of that. But we have continued to study this as time goes on. Schools were really only shut down for the first year of the pandemic, if that. And so while there are societal consequences, the direct impact of those public health interventions is no longer present. And these later studies really show that even after things were back to normal, although you could argue today is not very normal from a lot of other perspectives, but that the connection remains, so that there are still new onset of symptoms, and particularly cognitive and psychiatric or psychologic changes after children are infected with COVID. So what have we seen in our clinic? A little bit about why I'm giving this talk and my background. So I'm the director of the Children's National Post-COVID Program Clinic, or POCO, as we affectionately refer to it. It is a multidisciplinary clinic, and we've been open since May of 2021. And our core group of providers that every patient sees is infectious diseases, myself and a team of nurse practitioners as our sort of the quarterback of the visit, psychology and physical medicine and rehabilitation. And this group was chosen based on sort of early literature published out of the adult long COVID world and clinics that were being formed in the UK and elsewhere, identifying this sort of, here's what we can do now, and here's how we can support patients while the science and medicine and all the rest of it catches up. And I still think that these three core supports, especially psychology and PM&R, are critical. And we'll talk more about that in the subsequent slides. Additionally, we have cardiology, gastroenterology, neurology, and hematology that see some patients, but not all, depending on symptomatology. So this, this experience and seeing over 350 patients come through our clinic, looking at that clinical data, has given me a lot of insights, and as well as Dr. Herbert, on kind of what's going on here. So a little bit about our process. So Dr. Herbert and we often have another psychologist in clinic will do an evaluation. So every patient during their mini appointment through their multidisciplinary evaluation gets an interview as a consultation. And it's really driven at assessing pre and post-COVID social cycle functioning, including academics, their social relationships, sleep, appetite, neurologic functioning, any pre-existing history of psychiatric disorders like mood disorders or anxiety, other stressors, and then any other relevant medical history that might play into factor. And all of our patients and their parents complete a promise score as a standardized, objective way of evaluating their like self-reported stress in different domains. So we look at physical functioning, but also social well-being, overall quality of life, mental well-being, and a series of different things. And that's something that we then can trend over time. We plan to start repeating those with follow-ups to continue to monitor that more objectively. But it's pretty standardized across the research world as well. So just going to go through a few case examples. A lot of you, I think most of you on the call, are probably parents of children with long COVID, or maybe suffering with long COVID yourself. So you might see you or your child in some of these descriptions. But you might see kids that are different. And the main point of this is that this is an extremely heterogeneous disease, and we see lots of different flavors of impact in kids. So first case is Jade, and these are composite cases, not actual patients. Is a 15-year-old who comes to us 6 months after her COVID infection. Pre-COVID, she was a busy student athlete. She had pretty good grades, very robust social schedule, maybe had a little anxiety, type A personality, perfectionist about school, sports performance, like many of us. After COVID, however, she developed extreme fatigue, has been unable to go to any of her sports practices, which she, generally loved. Now is attending all virtual classes, has brain fog, her grades have really struggled. She does have this episodicity, so she, pushes and crashes and sort of cyclical symptoms to some degree, although certain aspects could persist. And then has really had increased anxiety about school and sports, and also a lot of anxiety about the future. And what happens if she gets COVID again? What happens if she gets the flu? What is life going to look like when she goes to college? So a lot of anxiety about, potential next steps. Another example is Hayden, a 10-month-old who we're seeing almost a year after his COVID infection. He does have pre-existing history of some neurocognitive disorders, particularly ADHD and a specific learning disorder, and already has an IEP in place for that. And has pretty average peer relationships. But after his COVID, he has developed extreme fatigue, headaches, memory concerns, and really is in need of some additional accommodations beyond what his IEP already had in place. He feels like his peers have moved on. They don't understand him. They don't want to, try to wait for him. And he's lost interest in his previously enjoyed activities. And then last case example is Gloria, a 17-year-old with 7 months of COVID-19 infection, or after her infection. Prior to COVID, she was pretty typical, like no medical psychiatric history, good social relationships, average academic scores. And after COVID, she developed extreme fatigue and headaches, as well as some concerns about memory. And she has gotten some accommodations at school, things like, an elevator pass or increased time between classes to address the fatigue, but has been able to continue to attend school in person. And she has continued to do some of her sports activities, but adjusted to be more consistent with her physical needs. As an example, she used to play on the basketball team. And while she cannot necessarily participate in games all the time, she now helps as an assistant coach on the sidelines, and does participate at practices to a limited extent. Similarly, has modified social activities, but has continued to stay engaged with her peers. So really, the point is this is all long COVID, and all of these kids to some degree have had an impact on their mental health. But it's really, really variable. So, heterogeneity is the name of the game. Individualized evaluation and treatment is also the name of the game for this population. So, some youth really, had some pre-existing neurological and psychiatric conditions, and we do see a lot of kids with pre-existing ADHD in our clinic. I think that's a national trend in terms of diagnosis increasing. And some of those kids, those symptoms may stay relatively stable, but they may get a little bit worse. Or we've had some people who, may have truly had ADHD, but have been tipped over to their ability to kind of cope and function with that, and achieve a new diagnosis in their post-COVID era. Other youth like Jade, she didn't have any history of pre-existing neuropsychiatric symptoms, but now has symptoms like brain fog, headaches, anxiety, depression that's worsened significantly. So, she had taken a significant hit, and actually developed some new true pathologies, or clinical diagnoses rather than just sort of the neurotic level of anxiety. But then others like Gloria maybe have really bad physical symptoms and even some neurological, but don't have the accompanying psychiatric concerns. They're able to function well enough, and have other abilities and ways to cope. So it's a very mixed bag in terms of how kids are affected. And so our approach is that, each youth may benefit from a similar core set of supports, although some may already have those supports in place, in which case there's less for us to do to kind of help them build that. But others may require additional, psychotherapy, medication, and in other support beyond kind of the core things that we look to. So, psychological treatment. Dr. Herbert's approach in our clinic is really based on tools. So she really, is here. We are unable to sustain longitudinal therapeutic relationships with the patients from a psychology standpoint. So what I mean by that is that we don't have therapists on staff. They don't take over day-to-day counseling or therapy with patients. But what we can do is arm patients with tools that they themselves can either use to help cope with their new diagnoses and some of the mental health issues that they're struggling with, and or they can use with their therapists in the community to make sure that they are working on the right set of skills and the right coping mechanisms to deal with what they're dealing with. One caveat on that, which I can't ignore, unfortunately. So I talked about, getting licensed mental health professionals and being plugged into that. But that is a significant barrier to care. So, as you can see on this graph, which is from the National Survey of Children's Health Data, which is a survey done by HRSA, or the Health Resources Service Administration, or was done annually for several years. And you can see that there is a trend, in issues and increased problems with mental health in children and adolescents, and that predates COVID. You can see especially the rates of anxiety were already starting to go up in 2018. Similarly, depression and any overall mental health or behavior problem was also going up even before the pandemic started, and that has only accelerated significantly since the pandemic. And so there was already a known shortage of mental health professionals, especially for children and adolescents. There have been some studies and reports put out by, I think, the same group, HRSA, that estimate that 1/3 of the US population lives in an area where there is defined as a mental health professional shortage area. So sort of like a food desert for those of you that study socioeconomic determinants of health. So really, I think it's more than several hours away or difficult to access a mental health professional. And doing some estimates, it's estimated that there's only 65% of the ideal level or number of child and adolescent psychiatrists in this country, 57% of mental health counselors, and 55% of psychologists. So access, even if you are in an area where you can get it, is going to be competitive, have long wait lists, and that can be a problem. I will say that telepsychiatry and telepsychology has helped offset this a little bit, and there have been some policies put in place that allow consultation or therapy across state lines, which is something I am jealous about and wish we could get in the medicine side of things. But it's still an issue for sure. Okay, so going back to that with that depressing fact in mind. So here are some of the things that Dr. Herbert really works on in our patient clinic. There's really 5 or 4 domains that she intervenes with. One is kind of the school accommodations, the educational side of what's happening with our patients. 2 is helping optimize routines and other lifestyle factors that are disrupted because of the illness that we're all, that patients are going through, and only sort of spirals and makes things worse. And a lot of that is in support of the implementation of medical recommendations. There's anxiety management, and then mood fluctuations are kind of the 4 buckets that she often manages. But first, above anything else, the main thing that we support in our clinic and that Dr. Herbert and her colleagues do is listen. I hope that we're turning some pages in this country where more doctors are aware of long COVID in children and believe that it is a thing, and that believe that patients are truly suffering. But medical gaslighting is real, and I still hear reports from patients every week that, somebody that they're dealing with has no idea about this condition and what's going on. So a big part of what we do, is validating, normalizing, saying, hey, you're one of 350 kids that we've seen in this clinic. This is definitely a real thing. You are truly suffering, and there are medical reasons for this. Addressing as best we can, or really acknowledging the fact that, we don't necessarily have all the answers. We don't have evidence-based medical treatments yet. We don't necessarily even have great biomarkers or labs or other ways of helping, which is scary and frustrating. So acknowledging that and acknowledging sort of the stress of the uncertainty, like a lot of teenagers want to know, like, am I going to get better? Am I going to be able to go to college? Am I going to be able to get a job? And we're starting to learn more about the trajectories of these things, but we don't truly know what this is going to look like. We need, 5 to 10 years worth of data to truly know, what the trajectory looks like in all of us, but especially in those that have ongoing symptoms after COVID. So touching on the specific interventions, so school accommodations, I'm sure all of you are well aware, but that long COVID can be considered a disability under the Americans with Disabilities Act in Section 504. And so in public schools, patients, children are, eligible for a 504 plan or medical accommodations plan. And that can be a wide variety of things. I will say we've had a huge range of experiences with schools. Some are really great, or some are, really great in the administrative level, but then have highly variable support and adherence in the individual teacher level. Some are not so good. And then we have patients in private schools, which unfortunately is not beholden to 504 in the ADA. And some schools are amazing, and other schools say, well, if you can't cut it, you just have to leave. And so a lot of the educational setting is important. I'd be curious to see what, if any of that might change with the shakeups in the Department of Education. But right now, for those in public school and those that have amenable private schools, getting a 504 plan on the books is super helpful with those that are able to continue to go to school. So examples of sort of the recommendations or some of the accommodations is, reducing the number of assignments rather than just giving more time, encouraging teachers to focus on mastery of a subject rather than, repetition and busy work. If there is additional time, making sure, it's at least a week, not just 24 hours, because we know crashes can persist for many days to even longer. but also other accommodations, physical accommodations, elevator passes, increased time during passing periods, sitting outside during lunch to avoid more COVID exposure. There's lots of different things, that we work with families on an individual basis to, try to help with education. Another thing Dr. Herbert, really focuses on is building new routines. So, long COVID is a chronic illness. It is a new chronic illness, and that completely puts people's worlds, like flips them upside down, puts them on their head. As most of you are probably painfully aware. But that, so it may shake up our routines as we know them, but we do know that especially children really benefit from routines and structure and knowing what's coming next. So within the constraints of what you're dealing with, setting routines and using SMART goals, so this structured approach for something that's specific, measurable, attainable, relevant, and time-bound, can be very helpful in at least minimizing some of the psychological distress that's being experienced. It just has to be changed to something that is feasible for that patient. So in some of our kids that have, pretty bad fatigue, have some to minimal PM, one example, we say is like, set a time limit and plan to walk the dog. And in one case, on Monday, Wednesday, Friday this week after school, I'll walk the dog for 10 minutes. Or it might even be just every morning, I will get up at this time, I will sit up in bed, I will 10 minutes later go brush my teeth. But setting something that works within your new structure, can be very helpful, taking away that uncertainty and chaos as much as possible. And then kind of the other more clinical tools, I would say that Dr. Herbert focuses on. So cognitive behavioral therapy. And I want to say, first off, it's a tool. It's not a treatment in this case. So we know that this is not all psychological, but CBT is a way of reframing our thoughts and our feelings and our behaviors, and not letting that part of our brain sort of outsmart itself and make the situation worse. So, it helps basically break, these spirals or cycles that we get into, change unhelpful ways of thinking, and learn patterns of sort of helplessness or unhelpful behavior. And so that can help, at least, again, with the psychological stress of what's going on. It can help the way you respond to the barrage of negative things that are happening to you physically. And really is empowering. The goal is to empower individuals to, think through their own stuff and tackle problems head on. And how that works in long COVID, kind of goals of that would be to increase participation in meaningful activities. So we like to ask all of our patients, what is one goal that you want to get out of this visit, or that you see, improving in the short term? And that might be attending this one concert in a month, or that might be just getting back into school one day a week. But finding, ways to improve that with this mental model. Also managing new symptoms or new episodes, so that your brain, your super smart brain, is not making it worse. And reducing worries about that increased pain and the symptoms and your experience of it. And hopefully overall improving the quality of life a little bit. So this is done, again, complementary and hand in hand with our medical recommendations, especially any recommendations about activity, physical functioning, autonomic rehab, those sorts of things that PM&R will do. And using those, basically, again, teaching a skill, a life skill that frankly all of us would benefit from, but most of these kids haven't had to have previously because they were able to function and often thrive and be at the top of their game, without giving it a second thought previously. The other piece that she really focuses on is acceptance and commitment therapy, which is described as helping individuals learn to stop avoiding, denying, or struggling with inner emotions and accept them as deep feelings, appropriate responses to the situation, but not let them get in the way. So that's just, a lot of that is sitting down saying, I am tired and this sucks. And I cannot run, I cannot walk right now. But I'm going to work on figuring out how I can make that better. Again, not being present is a lot of it. So just not focusing on that barrier as an immovable force. So again, goals of this, it's not that kind of acting as I feature in the picture there, but a different kind of act is to increase participation in those meaningful activities, manage episodes more effectively, and improve that quality of life. And there's kind of 6 core processes that she goes through with our patients, which, is taking all of your emotions as they come at you. Not good, not bad, just accepting all of them when it comes to long COVID, and then changing the way that you respond to those distressing thoughts. And not judging yourself, not saying like, I did something wrong in this world or I'm being punished, just accepting those feelings and moving on from that. So again, targeted at the experience of all of the medical badness that is happening to these patients and helping them, not spiral or make things worse, which is a challenge. So, in conclusions, there obviously are plenty of neurological and psychiatric concerns reported in our patients with long COVID, and that school accommodations especially are something that everyone should have if they don't already, as well as other accommodations at home, at activities. They're not legally bound, but certainly something worth discussing and talking about, as a lot of us would do. If you don't like a certain food, you work around that, or you have dietary restrictions. Same thing with the long COVID physical symptoms that you're struggling with. And then using some of these like clinical strategies, either with your therapist or, applying some of these skills individually, such as CBT and ACT therapy. But, obviously, all of this is sort of a Band-Aid. So we're trying to support as we get through the rest and hopefully learn and find cures and better, treatments. But it's something that we can do and that patients can do and empower themselves to help. So I just want to give acknowledgments. This is our clinic staff at an Orioles game last year. Dr. Herbert in particular is a huge Orioles fan. So thank you so much for inviting me to speak at this webinar, and I'm happy to address questions. I saw a few of those pop up in the chat.
Yeah, thank you so much for that. That actually was, I really believe, was truly helpful. And I just want to emphasize what you were saying about validation. And I developed infection-associated conditions when I was a child. I was told it was anxiety. Most people dismissed it. It was the 90s. No one knew very much. But I can tell you, I still remember the day the first doctor validated what I was feeling. That was 30 years ago, and I still remember it. So to any clinician out there listening, it's that powerful, you know? So before we move on to question and answers, I would like to take an opportunity to do one more poll. And while we're doing the poll, if anybody has any additional questions they would like to put in the Q&A, now's the time to do it. The poll is in the chat. And the question is, which mental health related issue affecting children with long COVID do you consider the most pressing? So we have the selections of lack of understanding from providers, lack of resources and support, the stigma around mental health, the isolation and impact on daily life, or other. Isolation's got 2. Lack of understanding, yeah. Lack of resources. Yeah. So it looks like we're seeing lack of understanding from providers take the lead. Yeah. Isolation and lack of resources. Interesting that stigma didn't even score on it in this poll so far. Very interesting. Thank you, everybody, for answering those polls for us. Okay. Now we're going to open it up to questions from the audience. Again, please feel free to add the questions to the Q&A box and we'll get to as many as we can. Just going to pull them up here. Let's see, the first question, let's see. I see Richard answered this one, but I'd be curious for others. So from your perspective, so I'll ask each one of you, from your perspective, what do you think is most urgently needed to help children with long COVID who are experiencing mental health challenges now? So, Dr. Yonts, would you start?
Yeah, I mean, frankly, it's hard to disentangle from all of the other issues that we have. So, better prevention from COVID infections, better treatments for the physical manifestations of long COVID. But, I think recognition of psychological suffering, even at a PCP's level, regardless of the source. And that's, something that's been a movement in the pediatric world is getting, primary care pediatricians and physicians to recognize these things better and screen for them. But, finding that struggle and addressing that and then also working on the physical symptoms as well. So I think just better recognition, better screening, more time for pediatricians to talk to families, which is all, well outside of our control and our pay grade. But I think not letting these things linger is a huge thing. And that goes for the physical and the rest of long COVID too, as early detection and recognition.
Right. Dr. Fitzgerald, what would you add?
Yeah, I think what Dr. Yonts and Dr. Gallagher had said on an individual level is absolutely correct, but I'll add, on a societal level, on a global level, we really need more research. We need to understand what's going to happen long term to children. Kids are going through, as I said in my talk, so many changes, so many aspects of neurodevelopment, and we don't yet know what the impact of long COVID is on that development. We can't answer the questions that Dr. Yonts' patients are having. We need to be able to give them better answers, and we need more research, and we need more therapies for them.
Right. And then Dr. Gallagher, you'd written in your response, effective assessment of child and adolescents' individual mental health challenges, followed by individual treatment, including consultation with school personnel to understand the youth's needs. Would you like to add anything to that?
Well, I think what's really important from Dr. Janssen and her colleague, Dr. Herbert, there is real true heterogeneity, and we need to recognize that. So I think that what can be helpful if people are doing things practically, there are some sources of things that can be used, and there are some in the public domain where there can be a kind of review of kids' mental health and behavioral functioning with some normative information. There is the pediatric symptom checklist. There is, the ARCADS 25, and then there's also the strengths and difficulties questionnaire. And those can be used even by other practitioners. It doesn't have to be a mental health practitioner to be able to say, here's what is occurring for this particular child. And then again, the individual, design of the treatment and the school accommodations is best. So it does involve some careful individual review using the insights from group studies to know what's likely to be present.
Yeah, thank you for that. We have another question. What barrier to obtaining supports for children is the difficulty in getting diagnosis for long COVID? So sounds like a difficulty getting the actual diagnosis, especially with coexisting mental health issues. What can we do to work around this problem? So we hear that a lot, that, things will get blamed on pre-existing mental health issues. Does anybody have any kind of thoughts?
One thing that's important that I think is really important to understand is that if the brain is affected and if there is clear indications from reports that things have gotten more complicated, more difficult following a COVID exposure, we can say that that people can have problems exacerbated. So that there may be a condition that's ahead of time, but it may have gotten worse. And so that we need to be able to keep that in mind and not say, oh, this is just an exacerbation. And we do think we have to do a careful history because there are studies that are being initiated to see if there are some medical treatments for long COVID and the complications. And so that a person where that's known might eventually be able to use those treatments to reduce the impact of this virus in the long run. And so that we need to do careful histories and recognize that people with prior conditions are actually more at risk. We actually know that in all the systems, people with respiratory illnesses were more impacted by COVID and having more likely to be long COVID and the same is actually true if you look at the psychiatric literature. People with psychiatric conditions were more likely to have more complications.
Right.
And so that's something that we need to recognize.
That's a good point.
Yeah, I was gonna, I think it's a good general practice as a physician and clinician, if something's getting worse, to ask why and to try to figure out why, not assuming it's just the underlying condition and the natural progression. So some of that line of inquiry, is there a recent infection? Was there something else? Obviously, for kids that are, minimally symptomatic or asymptomatic in this world where people are no longer testing, that makes it a little bit more challenging. But yeah, I think that should be a baseline. If things are worsening, absolutely should check on that. And consider long COVID as a diagnosis. So a lot of that's unfortunately provider education and maybe a little bit more pushback from parents saying, no, this is worse than it was. And it was a recent change. Because it is a difficult issue to entangle, especially you throw in adolescence and everything's changing, but their history taking is the ID, doctors like favorite tool. So that's a huge part of, I think, what needs to happen.
Yeah. Go, Megan. Yeah.
Yeah, and I can say, from a neuroscience perspective, there's been, long time reports like that preceded COVID that after certain infections, people were more at risk for suicidality. For example, people with major depressive disorder were more at risk for suicidality. And so that's long established is that, this degree of inflammation can exacerbate psychiatric health symptoms. And these were in, with viruses that didn't necessarily have the neurological impacts that we know that COVID does. So I hope that people are not going to have a hard time getting their providers to buy into this, idea, because I think this preceded COVID, and there was recognition of that in the field even before COVID. And now it's really coming to a head with long COVID.
And ultimately, is it important because it drives the treatments? Like, is that understanding this?
Yeah, I think I would hope that it will drive the treatments and looking more into, the underlying causes of the exacerbation of symptoms in people both who had pre-existing mental health conditions and those without.
Right. Okay, I have one more question. My child consistently cannot remember anything that happens approximately 8:30 p.m. each day. However, he has no trouble recalling events that occur before that time. Have you heard of similar cases? A specific time every day. I can say, so I've talked to about 500 families at this point, and I have not heard of a particular time of day. My next question to you would be, what does he do before that and consistently? I have heard of after a certain activity, then you experience something called post-exertional malaise, where it becomes sometimes even hard to put sentences together because your brain is just so tired and you kind of go into a shutdown. I have definitely heard of that, where memory gets complex, trying to recall things.
I think we have to consider, concerns that have come from other neurological conditions. There are certainly adults that when things are changing with dementia, there's these issues of sundowning, that there's less stimuli, the light is less, right, and there may be some issues that make it difficult, and there could be accumulating kind of exertion, malaise that may be some of the explanation. It's like after a long day, everything is getting to be more of a complication, and it may not necessarily be memory, but to be able to remember something, you have to pay attention to the details. So, some cognitive memory issues or cognitive concentration issues may be, building up over time, and it's making it hard for a person to remember. So those might be some of the factors that play a part.
Yeah. We're almost out of time, but there's one question I wanted to get to quickly. Just what are some of the differences between long COVID and PANDA symptoms? And I'll just note, I believe there's research coming on that.
So I just typed in the chat. I mean, being a little persnickety about terminology. So PANDAS is a subset of PANS, which is, pediatric acute onset neuropsychiatric symptoms. PANDAS is very specifically related to group A strep infections. That being said, PANS, we know is triggered by a lot of different infections, and COVID certainly is one of those. I think the issue that clinically I run into, and I'd love to hear more from the other two, is that the definition of PANS is very strict. So you have to have OCD or restrictive eating disorder that are new onset, as well as a handful of other symptoms. And I see a lot of patients with long COVID that have that second half of those other symptoms, but don't have the OCD or RFID or restrictive eating disorder. So, I think like all of these infection-associated chronic conditions, it's probably a spectrum. There's probably some degree of similar pathophysiology happening with the brain, but it's not specific. So I think it's a challenge, but I'd love to hear what the rest of you think. I think it's probably, again, inflammation and other pieces.
Megan, did you? Oh, go ahead.
I don't have much to contribute on this issue, but I do think that we want to be, that investigation, that kind of research should be done. I think we again keep having to recognize and think about heterogeneity. I think that we don't understand the brain well enough to know exactly where these things reside and where they go and what systems they affect. So I think we have to kind of do the research.
Yeah, I do believe there is some research being planned. So we're going to go ahead and right here because we're out of time. As we close, I just want to remind everybody that mental health is part of the journey of living with long COVID, and no one should have to face it alone. Building community is essential, not only for support, but also for the strength for our collective efforts to improve care for children. I wanted to share that Long COVID Families will be launching a private discussion forum this fall to help families connect, and we'll be sharing updates about it in our newsletter. And thank you again for joining us today. We hope to stay connected as we continue this work together. And please visit our website, follow us on social media, and to stay informed and to help spread awareness. You will receive a brief survey after the webinar. Please take a moment to complete it. Your feedback will help us guide our future programs, and whatever questions we did not get to, we will answer them and send the answers out. Thank you all very much for being here, and have a good day.